So good evening. I am Amy Laster. I'm with the Foundation Fighting Blindness. I serve as the Vice President of our Science and Awards Program. And I have the pleasure of having a conversation on understanding the basics of retinal degenerative disease with two excellent ophthalmologists that will share with us, give us a really good overview of retinal degenerative diseases, the causes, the symptoms, and the treatments from their perspective as ophthalmologists. So today we have Dr. Rachel Huckfeldt, who is a full-time member of the Inherited Retinal Disorder Service at Massachusetts Eye and Ear. She's a retinal specialist with expertise in inherited retinal degenerations, as well as AMD and other conditions. Before coming to Mass Eye and Ear, she did her postdoc fellowship with Dr. Jean Bennett at the University of Pennsylvania, as well as a retina fellowship at the University of Iowa, and she completed a fellowship with Dr. Eric Pierce. And we're very pleased to have you here with us, Dr. Huckfeldt. Also, we have Dr. Jacque Duncan, who is also an ophthalmologist at the University of California, San Francisco. She specializes also in treating retinal degenerative diseases, such as RP. She is skilled in using experimental techniques to prevent or slow these conditions. And in her research, Dr. Duncan is studying treatments to preserve visions as well as devices to stimulate visual perception. With that, I want to stop and turn it over to Dr. Duncan to kick us off with how degenerative diseases can cause vision loss.
Well, thanks very much for this opportunity to speak to the visions community this year. Thank you, Amy, for inviting me in. It's a real pleasure. So retinal degenerations represent a very variegated and heterogeneous, kind of complicated group of diseases that all share in common one thing. The vision cells, or the cells in the body that perceive light, don't survive the way a normal eye, the way they should in a normal eye. Over the course of the period of the person's lifetime, patients begin to lose their vision at some point or another. And depending on which kind of vision cells are affected, primarily, patients will either experience trouble with night vision and side vision earliest, or difficulties with central vision and recognizing fine details, reading letters, things like that. In general, retinal degenerations get worse over time, and they're all caused by genetic mutations that are inherited as part of the DNA that we're born with, which cause the vision cells not to survive as long as they should and not to work as well as they should. So the symptoms tend to be difficulty with night vision and side vision if it's a rod cone degeneration where the rods are primarily affected, or difficulty with central vision, fine detail vision, color vision, and sensitivity to light if the cone vision cells or the central vision cells of the macula are affected earliest. Retinal degenerative diseases are inherited in a number of different ways. It can be inherited. They do run in families, but more commonly than not, nobody else in the family has a history of a similar vision problem. And that's because probably the most common way of inheriting this disease is a way known as recessive inheritance, where it's autosomal recessive. You inherit one changed gene from your mom and one changed gene from your father. And when you have two copies of a changed gene, that's necessary for you to have a vision problem. Usually in that case, both parents have normal vision, but each child they have together has a 25% chance of being affected. There are other kinds of inheritance, including X-linked inheritance, where the disease is carried on the X chromosome or carried in females, in whom the disease is usually less severe or sometimes not at all noticeable, that is then passed on to roughly 50% of their sons, who tend to have vision problems that are more severe than the women in the family. And the third pattern, most common pattern of inheritance, is autosomal dominant. It's actually probably a little more common than X-linked recessive, but autosomal dominant disease is a pattern where usually one parent is also affected, and then they have a 50% chance of sharing or passing down that change gene with each of their children. So oftentimes in autosomal dominant disease, there is a family history where people say, yes, one of my parents had a similar vision problem at a similar age. Rare forms are mitochondrially inherited, which comes through the mother's line, but the expression of that can be very variable and usually affects other parts of the body in addition to the eyes. So those are the main patterns of inheritance.
Thank you. And Dr. Huckfeldt, do you want to just kind of give our audience a sense of what to expect when they're visiting a retinal specialist?
Sure, and I'd like to echo Jackie and being appreciative of the opportunity to be with you all. If somebody gets referred to my clinic or Jackie's clinic for suspicion of an inherited retinal condition, often the first visit is a pretty long visit because we want to really thoroughly evaluate and understand how somebody's vision is working and what is happening with their retina. So that often can end up being a solid half day of testing. And usually we start just by talking to really understand what aspects of somebody's vision they're having difficulty with. And we go from there to testing that initially is pretty familiar. So checking the visual acuity, how someone reads the eye chart. Then we move on to the perhaps less familiar. We map out people's peripheral vision with what I describe to children as a really boring video game where patients are asked to click a button when they see a light. That's often followed by tests of color vision. And then we move on to a test called an electroretinogram. And that's a way that we can measure the electrical activity of the light-sensitive cells that Jackie mentioned, whether it's the rod cells we use at night or the cone cells we use for daytime and color vision, and really assess to what degree one or both of those types of cells is having difficulty. That test we like to prepare people for because they have to be dark adapted for about half an hour ahead of time. That just entails having patches over their eyes to help them be as sensitive as possible to the dimmest of dim lights. And then there's a specialized recording electrode that we use to record the electrical responses as patients look at a display of bright lights. And that recording electrode can be as simple as a wire that just sits underneath the eyelid, or it can be a specialized contact lens that sits on the eye. But either way, it's a painless test. And then we usually finish the evaluation by taking specialized pictures of the retina to really get a sense of its anatomy and structure. After that, we like to do an examination of the eye and the retina. Good old-fashioned evaluation still is important even with our technology. And then next is my favorite part. It's the opportunity to sit down with the patient and explain what we're finding and hopefully put it in terms that are understandable and help them understand why they might be experiencing what they are and why we're arriving at the diagnosis that we are. And I should add that point, if we do find things that are consistent with an inherited retinal disease, I get to turn things over to one of my really important team members, which is a genetic counselor. Because as Jackie alluded to, we know that these conditions are caused by misspellings in single genes. And we think genetic testing is as important a part of the evaluation as anything that leads up to it. And so with the help of a genetic counselor, we can review the types of inheritance that Jackie talked about, review the family history, and figure out the best way to proceed with genetic testing for that patient.
So along the same lines, can you just expand a bit on genetic testing in terms of, is that for everyone or some people, and the process?
Sure. So if we have clinical findings supporting or suggesting a genetic or inherited retinal disease, that's the situation in which we would recommend genetic testing to start with for the patient. What many of us do is screen about 250 to 270 genes that we know are involved in inherited retinal diseases. So we're not looking at cancer genes, we're not looking at Alzheimer's genes, we really restrict our focus. And all it entails from the patient is signing a consent form, and we want them to understand the process, and then typically going to our lab to leave a sample of blood. Sometimes if people are squeamish or if they are conducting this part of the visit by telemedicine, we can send them a tube to submit a saliva sample with. And then the lab does the hard part and does an analysis of the genes of interest. And about 2/3 of the time when we get results back, we can look down the list and see that there's a misspelling in a gene that we know can cause a genetic retinal condition like retinitis pigmentosa or like Stargardt disease. That's the point at which sometimes we will move on to family members if there's clinical reason to do so. And sometimes if we don't find an answer in that first pass, or we're not sure we found an answer, sometimes the genetic samples of family members can help us further refine the information we have on the patient.
And Dr. Duncan, do you have anything that you want to add regarding genetic testing and experience in your clinic?
No, I think Rachel summarized that beautifully. My clinic works a little differently because I am not fortunate enough to have a genetic counselor on site. So I provide some genetic counseling, and we work with a remote service called Informed DNA, by which the patient receives genetic counseling, where lots of questions are asked about your family members, and then they also interpret the results of the genetic test when it comes back. In addition to, I will also discuss with the patient the results, but it's really nice to work with a genetic counselor because they're very well equipped to help patients understand these implications of the results of the genetic test. And they often will identify connections between family members that might not have been evident without their help. So genetic counseling is really important. In my clinic, I don't have a lab on site that does the genetic testing, which is the case at Mass Pioneer. Instead, my patients have been enrolled through the Foundation Fighting Blindness My Retina Tracker Registry genetic testing study, and a similar number and panel of genes are tested with pretty similar positive rates of identifying the causative mutation. But it's a little different depending on where you are seen, what kind of facilities are available at the center where the testing is performed or where your examination is performed.
So there are some individuals who may get a diagnosis very early on in life, and some may be adults. So can you talk a little bit about the difference in disease progression and the different types of inherited retinal degenerations?
Did you want me to address that one?
Sure.
Okay, sure. Right, so retinal degenerations can affect people of any age. And one of the things I like best about this career that I've chosen is I get to see babies, children, teenagers, adults, elderly people, and I get to know people, many members of the family over time. Some genetic changes cause vision loss very early in life, such that little children don't ever have normal vision. We often call that condition labor congenital amaurosis or early onset retinal degeneration. And it sometimes is identified by parents who will say they don't think their child's eyes are holding steady when they're looking at something, or they may not think their child is making eye contact or able to see things near them. Then the eye doctor, the pediatrician or the eye doctor will often recommend additional testing for that child, which often involves the IRD test that Rachel was discussing. And genetic testing can be very helpful in identifying the genetic cause of patients with labor congenital amaurosis. In fact, one form of labor congenital amaurosis is amenable to gene therapy, which has been approved by the FDA for mutations in a gene called RPE65. So that is one that is early in onset, but has an effective therapy. Even the earliest onset ones tend to get worse over time. So those early onset ones tend to be sort of the earliest in presentation and progress as the child gets older. Other forms like Stargardt disease is a condition which often presents in childhood or adolescence. It can also present in adulthood. Often typical Stargardt disease affects the central retina. So people have difficulty reading or recognizing fine details. And lots of different clinical examination techniques can give us the clue that that's what the patient might have. And then genetic testing is really necessary to really characterize the disease and know the exact genetic cause of Stargardt disease. And that tends to cause, classic, typical described by Stargardt disease tends to cause central vision loss to a much greater extent than peripheral vision loss, but mutations in the genes that cause Stargardt disease can also cause more widespread problems. And then, the other thing before we leave early onset disease, Usher syndrome is a condition where the vision is usually not bad or pretty normal at birth, but the hearing is affected. So children with Usher syndrome types 1 or 2 are born with hearing loss. If it's very severe hearing loss, they are called Usher syndrome type 1, and often those types of children will be referred for cochlear implants at early ages. Usher syndrome type 2 sometimes also has congenital hearing loss, but is sometimes not diagnosed immediately. It's sometimes diagnosed very early in childhood when children are learning to speak. And they will often receive hearing aids or speech therapy and not require cochlear implants. There's a third type of Usher syndrome type 3, which has normal hearing at birth, but hearing loss progresses over time. And those three have slightly different courses. The Usher syndrome type 1 tends to cause earliest vision loss with most severe and rapid progression. Usher syndrome type 2 and 3, depending on the study you look at, get worse over time, and 2 is probably a little bit more slowly progressive than 3. And then retinitis pigmentosa spans a wide range. There are early onset forms of retinitis pigmentosa, which also could be considered rod cone degeneration, where it tends to affect the nighttime vision earliest. Sometimes early in childhood, a person with retinitis pigmentosa will have difficulty seeing at night, and that could be identified by having trouble trick-or-treating or playing with your siblings outdoors at night or on a night hike or camping, times when we're not in well-lit environments. And then over time, patients with retinitis pigmentosa will develop kind of mid-peripheral side vision loss. It's not, the central vision is quite good, but they'll have difficulty with the vision off to the side. That gets worse over time. And again, that can begin in childhood, that can begin in adolescence, that can begin in adulthood. The pattern of inheritance sometimes goes along with the rate of progression at which it gets worse. The autosomal dominant ones tend to be a little bit slower in their rate of progression, even though they're sometimes diagnosed earlier because family members are attuned to this and are on the lookout for other family members who might be affected. Sometimes they're diagnosed before they have any symptoms. And the autosomal recessive or X-linked recessive forms tend to cause a little earlier onset and more rapidly progressive loss of night vision and side vision. So there are, as Rachel said, over 250 different genetic causes of retinal degenerations. And there's, even though we call them all by the same name, each of them is somewhat distinct. And so the rate of progression and timing of onset is unique in many cases. Even within members of the same family, there can be variability. So the most important thing is to get to a doctor who has seen patients with retinal degenerations before and can study either vision at the time of diagnosis and then follow over time. Because I think at the first time we see a patient, we have a snapshot, but as we see them over time, we begin to develop more of a movie and we get a better idea how things are changing for that particular patient.
Dr. Huckfeldt, do you have anything you want to add to?
I would echo what Jackie said about finding somebody who has experience with these diseases, because I think those of us in the field have all met patients who were given their diagnoses by very well-meaning doctors who weren't familiar with these diseases, and they were told various versions of, I want to prepare you for the worst, and the worst is coming tomorrow. And that's usually not the case. And so that's, I think, one reason for the importance of being with someone who understands being with a physician who understands the generally slow course of these diseases and can help track them and follow them and work with the patient over time.
And so along those same lines, let's kind of transition and talk about you know, the worst case is not tomorrow. And certainly there are some options that are available to those who are affected. Can you begin to talk about that?
Yeah, this is, I think, a very exciting time to be working in this area of medicine because of all of the therapies that are on the horizon. And all of these potential treatments really build on years and years of research that occurs in basic labs and clinical research, and much of this is funded by groups like the FFB. And as we think about potential types of therapies, we can group them into what I would call number one, neuroprotective agents, number two, gene-specific kinds of treatments, and then more of a stem cell and sort of vision replacement kinds of options. So let's start at the beginning. When we talk about neuroprotective drugs, we're talking about anything that helps the retinal photoreceptors and other supporting cells just stay healthier longer. So these may be drugs that, for example, improve the oxidative state of the retina, or just remove any kind of stress that can be damaging to photoreceptors that, because of these genetic mutations, already are struggling a little bit. And so along those lines, there's a trial coming up of a new agent in this class. And hopefully that will show some promising results. We'll see. For patients for whom we know a genetic diagnosis, I think many of us see the holy grail as being a gene-specific therapy. So if we know what gene is causing the problem, is there a way we can either introduce a new copy or correct a person's own DNA? And we can think of this kind of in two categories. One is gene replacement. This is something Jackie alluded to with the drug Luxturna that's been approved by the FDA. And this is the premise as introducing a new copy of a gene to the type of retinal cell that needs it. And using Luxturna as an example, this is a drug in which a modified virus, a virus that can't make people sick, is used as a delivery truck for the gene that needs to be fixed, a gene called RPE65. And so the virus's job is just to get that gene into the retinal cells. And to do that, it's injected into the retina through a surgery called a vitrectomy. And that vitrectomy, it's an hour-long surgery. It's bread and butter for a retinal surgeon. And it's a very effective way of getting the virus carrying the gene to where it needs to be. And this was studied in multiple rounds of clinical trials and ultimately got FDA approval several years ago. And that was really tremendous proof of concept that this kind of approach could work, that the FDA would approve it, and that insurance would pay for it. And there are now multiple ongoing clinical trials in various stages of other types of gene replacement therapies for other genetic retinal diseases. There are situations, though, where this approach of taking a whole gene and putting it into the virus won't work. For example, sometimes the genes are too large to fit into that virus. In the case of a dominant disease, sometimes putting in a copy of the gene isn't going to get you to the therapeutic outcome you want. And so something that I think all of us are getting more and more used to hearing about in the media is genome editing. And also often that phrase is immediately followed by the phrase CRISPR-Cas, genome editing. And this is a technique of really bringing a red pencil and an eraser to somebody's own DNA and actually making a correction in the DNA or a correction or modification in the DNA that they were born with to reach a therapeutic endpoint. And so that can be making a change that will make a gene be expressed correctly, making a change that will keep that gene from being expressed. There's multiple different ways this can be used. Some people refer to it as being genetic surgery. And this too is starting to enter clinical trials. Jackie spoke about a condition called Leber congenital amaurosis, and there is a genome editing therapy currently in phase 1-2 trials to treat a specific form of Leber congenital amaurosis. We can also hopefully get to the same endpoint of correcting a genetic defect by focusing a little bit further downstream in the process by which a gene is turned into the protein that a cell needs for normal function. And so another strategy is a therapy called an antisense oligonucleotide. And this is just a short little piece of DNA or RNA that can be directly administered into the eye and then interfere with how the misspelled gene is making an intermediate message that leads to a dysfunctional or not completely functional protein. And so the end point is getting a more normal protein that hopefully helps the retina function better. In contrast to genetic therapies like gene replacement therapy or genome editing, these antisense oligonucleotides are not a one-time therapy. They're something that would have to be administered probably repeatedly over someone's life. But we have really good precedent from diseases like diabetic retinopathy and age-related macular degeneration that delivering these kinds of, or delivering drugs directly into the eye can be a safe and effective way to help somebody's vision. And then we've already talked about, for 1/3 of patients, maybe we don't know the genetic diagnosis. That's an instance where the neuroprotective drugs are really attractive. And sometimes, regardless of whether or not we know a genetic diagnosis, somebody's stage of disease may be at a point where trying to replace the light-sensitive cells is a better strategy to hopefully restore some vision. And that's where stem cells can come into place. Stem cells can be taken or derived from fetuses or embryos. They can also be derived from somebody's own skin. So there's multiple ways to get to a stem cell that can hopefully be delivered into the retina and help restore some light sensitivity and some vision. And this is an area where inherited retinal diseases overlap some with acquired macular diseases like age-related macular degeneration, and that stem cells are an active area of research for both. And I think anything we learn from AMD has potential to help inherited retinal diseases as well. So I think we will hopefully see a lot of encouraging results in years to come. There are other ways, though, of improving or restoring light sensitivity to a retina that's affected by one of these genetic retinal diseases. One is a strategy called optogenetics, where you use a technique somewhat similar to gene therapies to restore light sensitivity to parts of the retina that aren't normally light sensitive. And then there are retinal prosthetics. So in those instances, we're making use of aspects of the circuitry between the retina and the brain that are intact, and using high-tech chips and computational software to help interpret the outside world into signals the brain can understand as vision.
Thank you. Dr. Duncan, in terms of all of these options, can you share with us any clinical trials that are ongoing and how one can learn about those clinical trials?
I'd be happy to. Well, Massachusetts Eye and Ear, where Rachel practices, is participating in, I think, more clinical trials than almost any place else. KCI Institute in Portland is another, and Retina Foundation of the Southwest at David Birch's are sort of the three ones. Maybe University of Michigan are the ones that probably participate in the most trials. We at UCSF participate in some clinical trials as well. There are many ongoing. I really probably can't enumerate them all and not leave something important out. So I would recommend that people check the clinicaltrials.gov website, www.clinicaltrials.gov, and just type in the disease that you have been told you have, and they will list the different clinical trials that are looking for patients and contact information for how to get in touch with them. In addition, people who are part of my Retina Tracker database will also receive updates. I received one this week about an optogenetics trial which is intended to restore sight to people with profound vision loss from retinal degenerations. Very importantly, when people are considering whether or not to participate in a clinical trial, it's really important to remember these are trials. These are not fast tracks to magical treatments that will help the patient. More often than not, clinical trials have to be done to determine whether something is safe and effective. And more often than not, they may be safe but not effective. They may be safe and effective in some people but not many, or there may be consequences that were not anticipated in early stages of the trial. So it's very important to participate in a clinical trial because you want to advance the science, not because you're hoping to get an early pass at a treatment that's going to help, because until we do the trial, it's unclear whether it's going to be helpful or not. So I have the utmost respect, admiration, and gratitude for all the people who participate in clinical trials with the clear understanding that they don't know if they're going to be helped by the trial or not. What they do know is they are going to help us move the field forward. And so it's very important before you consider participating in a clinical trial to have a clear understanding of what is required of you to be part of the trial, what the likelihood of harmful effects might be, and whether you as a participant are able to commit the time, energy, and possible exposure to different things that haven't been studied yet before you decide whether participation in a trial is right for you. It's not right for everybody. It's not right for everybody at every time of their life. Sometimes people are students in college and it doesn't make any sense for them to have to, it's really not feasible for them to participate in a way that's going to allow them to meet every visit. Or just depending on what, maybe the trial is at a place that's at a great distance from you, and getting to and from the trial would cause a very severe hardship, really be very challenging. So it's important to take all these things into consideration before you consider whether participation in a clinical trial might be right for you. If it's not right for you, that's okay. It's not, you haven't made a decision that's preventing you from receiving a treatment that would necessarily help. It's hard to know until, it's impossible to know until the trial is done, whether that treatment is going to be helpful and effective and safe. So we appreciate everybody who participates in trials. It's really important to know about the trials that are going on so that you can make an informed decision about whether participation in trial is or is not the right thing for you.
Great, thank you very much for that. We want to now spend the rest of our time together. You've shared so much useful information. I'm just answering some questions. So I will put the questions out and one or both of you can answer them. The first one just asks, how common are retinal degenerative diseases? I've heard of rare, and then sometimes I hear ultra rare. What's the difference?
So I think the number I quote and is widely quoted is that these inherited retinal disorders affect about 1 in 3,000 people. And that means collectively, they're quite common. But if you start breaking down the prevalence or the number of people affected with, for example, retinitis pigmentosa due to one specific gene, then that number falls more quickly. So it may be 1 in 10,000, it may be 1 in 30,000, it may be 1 in 50,000. For many of these things, though, these are very rough estimates. So certainly rare, but it's also hard to get a entirely precise number of how common they are.
And Dr. Huckfeldt, I think this is a question for you. Is AMD an inherited retinal disease?
Yeah, so it's a question I answer a lot. And we know there are genetic factors that contribute to AMD. So we know that there are particular genes in which there are so-called risk alleles, where if you carry that particular variant of the gene, you're more likely to get AMD than perhaps the person sitting next to you who doesn't have that copy. But it doesn't mean that you will. So we know that AMD results from a very complex mixture of genetic changes, environmental changes, factors we don't understand yet. And that's in contrast to the diseases we've been talking about so far, where if you, for example, have a misspelling in the RPE65 gene that causes LCA, or if you have 2 of those, we're pretty certain you're going to get the disease. So there's more of a one-to-one between the genetic change and the vision and retina problems that result from it. Whereas with AMD, it's a lot more variable. And so the genetic piece is a component, but it's not the underlying cause in and of itself.
Thank you. And this question really goes toward prevention. If your disease hasn't progressed to where you're eligible for a clinical trial, what can you do to keep your photoreceptors healthy?
Well, that's an excellent question, and one that I hear all the time. The one important thing to know is when people are given this diagnosis, they should realize that they didn't do anything wrong to get the disease. They didn't harm, they did not take care of themselves, and they didn't bring it upon themselves. They didn't do anything to necessarily deserve this. And similarly, there are not so many things that have been proven to help make things go slower that they have the ability to control. Things that people think might be helpful include eating a well-balanced diet, which is rich in dark green leafy vegetables. Some studies in the late 80s and early 90s suggested vitamin A might be helpful. Further analysis of this has suggested that it's not helpful for everyone and that it may or may not have a significant impact on disease progression, and it may be associated with side effects including trouble with the liver. So a related kind of compound would be dark green leafy vegetables contain vitamins called carotenoids, which are similar to vitamin A, but may be less likely to cause harmful side effects and may protect the central retinal central cells in the macula. People suggest wearing sunglasses and a hat is probably a good idea, although the research on that is also a little bit, it's a hard thing to study over the course of a lifetime, what impact exposure to sun has, but certain forms of retinal degeneration, including Stargardt disease or disease associated with the gene that commonly causes Stargardt disease, are likely made worse by exposure to a lot of sun, or a lot of bright light. So wearing sunglasses and a hat is something that everyone can do. There are some animal studies, some preclinical studies that suggest exercise is helpful in releasing neuroprotective factors like Rachel was talking about. That's pretty early and hasn't been studied well, but I think in general, having a healthy lifestyle, which includes exercise, dark green leafy vegetables, low-fat diet, not smoking is very important. And following the research so that you can be aware of what's going on in the field and learn about new developments as they come along.
Thank you. This question, is stem cell treatment a better alternative to gene therapy?
I think the answer to that is very specific to an individual's particular disease and the stage of disease. So even if I had equally effective stem cell and gene therapy treatments in hands, my answer would be very much tailored to the individual patient. So if somebody is, let's say, has retinitis pigmentosa and is still able to read fairly well, maybe has lost some peripheral vision and has problems at night, but can still read well, that's a situation where the light sensitive cells they have are probably better than, at this point in time, the light sensitive cells we could produce with stem cells. So if I had a gene therapy that was correct for their specific genetic form of RP, I would think that was a better treatment for them. In contrast, if somebody has, let's say, Stargardt disease and has lost a significant amount of central vision and probably has lost some photoreceptors, the light sensitive cells with that, that's a circumstance where a stem cell therapy would have better efficacy or effect than a gene therapy.
And this question, if two siblings have definitively been diagnosed with retinitis pigmentosa, is it necessarily true that both will have the same mutation in the same gene?
Most of the time that is the case, but it is not 100% of the time. There are we published a paper on a family where cousins had all developed retinitis pigmentosa, but different arms of the family had changes in different genes. So it is likely, if two siblings are affected similarly, that they are associated with the same genetic mutation. But it's worth having genetic testing to know that for sure. And oftentimes genetic testing of family members can be confirmatory in making sure that the same condition is present in both siblings and that the gene is truly responsible for vision loss, called situation where it segregates with disease, where if it's present in all the people who are affected and not present in the people who are not affected, then we're quite sure that that's the cause of disease.
So along the same lines, if someone wants to get genetic testing, are there specific facilities or a list of the genetic testing facilities that one can use?
I think it's a good idea to have genetic testing proceed hand in hand with a clinical evaluation by a retina specialist with experience in these diseases. There's certainly circumstances where the two things may be separated, but if that's the case, you want to have genetic testing under the guidance of a genetic counselor or a medical geneticist who is familiar with these diseases and all of the limitations and advantages of genetic testing. Like many developing parts of medicine, genetic testing has limitations. And so sometimes well-meaning doctors think more is better. And so they might order a much larger array, a broader range of testing than the limited set that we usually order. And sometimes that can produce red herrings that can send people down a pathway that may not be relevant to their retinal disease. So in many communities, even if there's not an inherited retinal specialist, you may be able to find a informed and experienced genetic counselor through a website like the FFB, or find local resources where there's the expertise to pick the right kind of test, pick the correct lab to do it, and then I think very importantly, walk you through the results and help you understand the results.
So I guess along that same lines, the question is, how do you find retinal specialists? And also a second part, how frequently should you visit a retinal specialist?
Well, I think the Foundation Fighting Blindness has a list of retinal degeneration specialists, or people who have expressed interest in caring for patients with retinal degenerations. There's Partners in Retinal Health, I think, was a program that used to exist. So I would, if you aren't sure who to turn to in your community, I think the Foundation Fighting Blindness is a good place to start. There are a number of centers that are participating in a consortium that we've created, which are located in the United States and around the world, many in Europe, Middle East, and South America. If you're anywhere near any of those sites, you're going to certainly be in good hands and be eligible to participate in a number of different kinds of clinical trials. Again, the Foundation Fighting Blindness website can connect you with those centers, as well as just, I think that would probably be a place that I would recommend people start if they are not aware of whether or not the retinal specialist they're seeing is someone who has expertise in retinal degenerations.
Another question here. If I have XLRP, am I eligible for Luxturna?
So XLRP, or X-linked RP, is typically caused by one of two genes, and neither is the gene that Luxturna is designed to correct. So this brings us back to the genetic diversity of these conditions and the specificity of some of the treatments for them. Turns out though, and this brings us back to some of the ultra rare discussion, that even though some of these genes are individually quite rare, sometimes there's a convergence of activity on finding treatments for them. So with regard to XLRP, or X-linked RP, there's one gene in particular called RPGR that is responsible for at least 3/4 of X-linked RP. And there are 3 companies working on a gene therapy for that right now. So even though people with XLRP aren't eligible for Luxturna, there may be treatments in the future that they are eligible for.
And just to echo that, this again underscores, emphasizes the critical importance of getting genetic testing. So unless you know what your genetic mutation is, it's impossible to know whether you would benefit from a treatment like Luxturna or whether you would be eligible to be in a clinical trial. So trying to get genetic testing on all patients with retinal degenerations, I think, is a worthy goal.
Thank you. So actually we have one last question as we're coming to the top of the hour on this session, and it's really a closing question for each of you. So you both are seeing patients every day, and so if you could just comment, what would you say to a patient that's just been giving a diagnosis for retinal disease?
I would say to have hope. It can be, of course, a very hard thing to receive a diagnosis and then be told that there's not a treatment right now. But I think just to know there is an army of people across the globe working so hard to develop treatments for these conditions. I think the second thing that I am continually struck by is the the rich, full lives that so many of my patients live and the amazing things they do. And so they have these diagnoses and they go ahead and they live their lives and they achieve wonderful things and they do what they want to. Somehow they find a really successful balance between having these conditions and not being stopped by them.
That is absolutely true. And in the meantime, it's not that there's nothing that can be done just because we don't have treatments. There's so many things we can do to help every step of the way. We can connect you with resources, including other members of the community who are similarly affected that can just give you some advice and support and shoulder to lean on, and connect you with low vision resources so that you can make the most of the vision that you have, even if it's not perfect vision. There's so many things you can do with adaptive technology and different kinds of approaches that will make it easier to accomplish things that they're harder now than they were before you started losing your vision. That you really are not alone in this fight. And there's a tremendous amount of exciting research going on. So there's a lot of reasons for optimism and hope that there will be treatments in the future.
Thank you. So Dr. Huckfeldt and Dr. Duncan, on behalf of the foundation and all of the Vision 2020 attendees, I want to thank you very much for sharing such helpful information and answering the questions. We really appreciate your time, and thank you very much.
Thank you.
Thank you very much.
All right. We are